So good morning, everybody. Welcome to this Health Foundation webinar on what will it take to get the NHS to net zero. I'm Jennifer Dixon and I'm going to be your chair here today. We know that healthcare contributes about 4 to 5% of global emissions. And at the recent COP26 in Glasgow, 50 countries made commitments to reduce emissions from their healthcare system, and 14 set targets to achieve net zero. The NHS actually is a leader in this respect. It's in year 2 of a strategy to reach net zero by 2040 for the emissions it directly causes, that's its carbon footprint, and 2045 for those it influences. It influences but not directly, and that's its carbon footprint plus. Nearly 2/3 of the NHS's carbon footprint, in fact, comes from its global supply chain. At COP26, the top 10 global suppliers of the NHS published an open letter in the BMJ to the 80,000 global organisations that make up the NHS supply chain, urging them to commit to work with the NHS to decarbonise their operations by 2045 at the latest. So what we're going to do today is reflect on COP26 that just happened and the extent that health and care featured, what was achieved, and how the NHS can make progress itself faster as well as on its supply chain. So we have a fantastic panel to do this. I'm going to introduce them now to you. Dr. Nick Watts, who will set the scene starting off. Thank you, Nick. Nick is the lead on the net zero strategy at NHS England as Chief Sustainability Officer, and he's also the lead of the Greener NHS team working across the country. And Nick is originally a medical doctor. Then we have Professor Mahmoud Butta, who is co-founder of the Sustainable Healthcare Group at Brighton and Sussex Medical School, giving you a wave. He's currently chairing a national study on improving environmental sustainability in surgery, and amongst many other things, he's also an ENT surgeon, and you can see him in his surgical fatigues there. Then we have Sonia Roshnik, who is Director of the International Climate Policy at Healthcare Without Harm, which is an international NGO. In this role, she oversees work to support healthcare systems in other countries make progress on net zero. Sonia previously worked in the NHS as Director of the Sustainable Development Unit and also as a clinician, and she joins us from very snowy France, where they're in the middle of a snowstorm, so we hope she doesn't break off in the discussion. And then finally, Adam Vaughan, we're delighted to welcome, who is Chief Reporter at The New Scientist. Adam has a very long interest and expertise in sustainability. He was previously energy correspondent and environment editor at The Guardian. So welcome to you all. Thank you very much for joining. So just before we kick off with this, we'll just have a bit of housekeeping. We're going to aim to finish at 11:45. We're going to have speakers say a few things first, and then we'll have an audience Q&A. So please get asking your questions. I think you all know how to use Zoom, but please use the Q&A box at the bottom of your screen to ask your question. And if somebody else asks a question that you see and you like it, then just upvote it using the thumbs up icon so we can see what's popular. Thank you for those of you who have already submitted questions. Don't worry, I have these and I'm going to refer to them. And also just to say that we are recording this, and the recording will be on our website within 24 hours. So please tell your friends, and those who need subtitles will add subtitles following the initial recording. So finally, for those who like to tweet, please use the hashtag THF, the Health Foundation THF, Net Zero NHS, and tweet away. That will be fantastic. Okay, so right, let's get going. And Nick is going to speak first for 10 minutes, and then our round-up panelists will respond. So over to you, Nick. Thank you.
Fantastic. Thank you. So excited to be here this morning. Wish we could be there in person. Another day, another year. A lot of stuff to talk about. Hey, the NHS is big. 1.4 million staff, 5% of national emissions, 36% of public sector emissions, 40% of public sector energy consumption. Big. The NHS, roughly the same emissions as the entire country of Denmark or of Croatia. So 10 minutes is not enough. time to talk about this. An hour and a half is not enough. We need days, years, you know. What I will do though is perhaps to be a little bit shorter and simpler, talk very quickly about what's just happened in the last 12 months. And then I want to focus mostly on what's going to happen in the next 2 months. I'm trying a new thing. I'm sick of talking about the past. I'm sick of talking about previous achievements. I want to talk about what we're doing going forward. So 12 months ago, you're exactly right, Jennifer. The NHS, world's first healthcare system to declare net zero 2040 for the stuff we control. 2045, we're good healthcare professionals. We understand we've got to go broader. 12 months passed and a heck of a lot of stuff happened. The team grew enormously. We gained new capacity, new expertise. We invested into climate smart infrastructure, £310 million into energy efficient, climate smart healthcare across the country. We innovated 2 new zero emission ambulances. We worked, Jennifer, with yourself and with leaders across the country and across the world to start to ask this sort of slightly more difficult question. Hey, that 2045 deadline, the emissions you don't quite control but can influence, that looks challenging because the power there and the levers are in your supply chain. We've got some hard policies that we have put in place. Within the decade, the NHS will no longer purchase from anyone that doesn't meet or exceed those commitments. And by within the decade, I want to be very specific, 1 minute past April, 1 minute past the 1st of April, midnight 2027. So with that commitment, we went out and we grabbed 15 of our closest friends, 15 of our largest, most important suppliers, scattered across a diversity of the supply chain, med tech, pharmaceuticals. Elise manages most of the scrubs and the laundry, Mahmoud, that you're wearing at the moment. The response was not, this is impossible. The response was, this is challenging, but we understand that this is the direction of travel. We're here with you. So over those 12 months, that and countless other things happened. The NHS is proud. We are cautiously proud to be able to say that we think we hit our in-year target. We hit that 1 year deliverable. Year 1 is easy. Year 2 is a little harder. Year 3 is harder after that. It gets harder as you go, not easier. We were just talking before the conversation, Adam, about being transparent about the numbers. 1,260 kilotons of carbon reduced in those 12 months. That's what we were aiming at, very roughly 352 in our estate, another 278 in our supply chain, another 400 or so in our medicines and the anesthetic gases and the inhalers. Couple of other stragglers out the side. That happened. We showed up in Glasgow and all of a sudden in a flash, you're right, Jennifer, the NHS wasn't alone, because it turns out we were right and our 15 suppliers were right. The direction of travel is set. This is where we're going. The world's healthcare systems are starting to realign towards a low carbon future. And so 14 other healthcare systems turned around and said, okay, the NHS has gone first, but we think that we can go faster in some cases. There are healthcare systems out there with commitments that are faster than ours. And there are healthcare systems out there that are bigger than us, believe it or not. By my count, they have an impressive suite of emissions behind those 14 healthcare systems. By my count as well, though, and again, Adam, you're right, the importance of transparency. Sorry, picking up on the conversation before. I don't think any of them have both a strategy and yet the capacity to deliver against these. If you're going to deliver against a big commitment like that, you need a strategy. Some of them have a strategy, and you need the capacity to go and do something about it. So in response, rather than complain, because complaining is easy and boring, the NHS is investing into a new international partnership with the World Health Organization to help to work with those countries and anyone else that wants to join, to share the expertise, to share the things that we've done wrong, to develop and lead and eventually move together towards a net zero healthcare system, not with 1, not with 14, but with 196 when we get there. So that's the stuff that's happened before. I said I wanted to talk about what's coming next. This is the far more interesting stuff, and everything I'm going to talk about is coming next in the next 2 months. There is a lot of stuff happening out in the system. We're in a new world. Number 1, you can expect a new net zero hospital standard. It's in beta phase right now. It is long. It is 700 pages. It will be applied to every single new build over £15 million, every single new site. It is challenging. It will challenge the way that we think about healthcare, but it's really important. It's not perfect. You can't build a net zero hospital today. Anyone that tells you that they have, I promise you, is lying to you. You can get there in about 5-6 years when the technology catches up. And so that's how the standard intends to improve slowly over that time. 1st of January, we're introducing new 10% weighting into every single tender the NHS has out, 10% into all of our procurement for carbon, for net zero. That is going to be challenging because not one person controls the procurement of the NHS. Thousands of people do. And so there is a huge education piece we have to get in place there. We're not there yet, but we're going to be able to get there, I think, in time for this policy to come out. And it's going to be a really significant shift to start to educate, start to embed that low carbon thinking into the way that the NHS procures. It will be aligned with a new sustainable procurement framework that we will run all 80,000, like you said, Jennifer, of our suppliers through. Over the next 2 months, we're going to be working with every single trust, every single integrated care system, 265 of them for those counting at home. Everyone needs a board level lead charged with meeting and looking at very seriously our net zero commitments and following that year after year. Everyone, every single trust, every single integrated care system needs a net zero strategy. I'm really excited to be able to report, and also a little worried. As of today, as of this morning, we got the data collection back a day or two ago, 81% of trusts and ICSs currently have net zero board leads. That is up from 6% 12 months ago. 82% of trusts and integrated care systems now either have or are, they tell us, a month away from completing their net zero strategy. That is up from 17% 12 months ago. It has come forward at an enormous pace. 81 and 82 mean that there are 19 and 18% that don't. And so if I have a plea to the people on this call, go and ask your trust. Do we have a green plan? Do we have a board level lead? Why the hell not? Everyone has to get there. And that's what we're focusing on over the next 2 months. We just saw yesterday, second reading, House of Lords, of the Health and Care Bill. That was exciting. It was interesting. We saw for the first time the introduction, a proper discussion about whether or not and where net zero sits within this. I think it was warmly received, and I think there's been a whole flurry of discussions over tonight and this morning to look at exactly what that turns into. A new duty, I would hope, we would expect onto integrated care boards, looking at ensuring that they help us meet that net zero commitment. Hospitals, procurement, strategies and green plans, the new health and care bill. 2 more things coming up in the next 2 months. Number one, primary care is an area of enormous importance. 20% of NHS admissions, 90% of patient contacts across the country. A few things we're doing. Number one, we're launching a new innovation competition for low carbon primary care to try to support and scale up those good ideas across the country. Number two, those integrated care system green plans, they are going to be essential. They are going to be the link between the 42 ICSs and our primary care community. And so we need every single one of our PCNs, every single practice to be leading and feeding into, and when those plans come out, to be leading and feeding into the next iteration of those strategies to make sure that primary care is essential there. And we're spending a lot of our time pushing on making those connections. Number three, some new investment and a new partnership with the Royal College of GPs. They do tools very well. They do guidance very, very well. There is good stuff out there and we want to support that. And so we're going to start to support the creation of practical guidance for individual GP practices that can go out into the system. What can I do? Not in 2040, not in 2024. What can I do tomorrow morning? The final thing that I think is going to be exciting and happening in the next 2 months. I mentioned those 2 ambulances. There are now 2. One is fully electric. It is carrying patients in Birmingham today. The other one is electric hydrogen, and it's a hybrid. It can go over 300 miles on a single refuel and charge. That is going to start carrying patients in a test over the next 2 months. 2's not enough. We need 5. So we're going to invest in a little bit more innovation, figure out a few different ways that you could run a zero emission ambulance. And then we're going to allow the trusts to try them out, the 9, 10 ambulance trusts to try them out over the next 2 years. We're going to test, we're going to innovate, we're going to slowly develop. 2.5 years from now, there's a new national specification coming out, I promise you, that says the NHS no longer purchases outdated ambulances, these zero emission ambulances. This is the future. I'm going to stop, Jennifer. That's the last 12 months and the next 2.
That's all great. Thank you, Nick, and for giving us a short-term horizon of practical things that's going to happen. That's great. Perhaps if I can just ask you a question before we have a discussion. It's a big one, and that is, the NHS has strategies, it has targets, it has sort of tools, it has guidance. What other things are in your armory to try to really more than nudge the system forwards and or even provide support?
Good question.
At a system level, I mean, yeah.
It's a good question. So look, there are some levers nationally that we have access to, right? And they are either large amounts of capital, and we're deploying that where we can. And you will see, in fact, Trust will see in the capital guidance coming out in a couple of weeks, no longer just a question of where do you spend your capital, your 12 billion, I think it is, on these categories, but also then which parts of this are spent on net zero. Start to report back precisely how is that capital contributing to the net zero direction that the NHS is heading. Obviously, there are important levers and powers in procurement. Obviously, there are important ways that we can set up and we can innovate and we can scale. But I actually think that stuff isn't the stuff that keeps me up at night. The difficult part is the stuff that we don't control directly. And by that, I don't just mean our supply chain. What I mean is there's 1.4 million healthcare professionals out there. What's the biggest lever to get to net zero? It's 1.4 million decisions made every single day. How do you do that? How do you create that movement? The NHS, E&I, we are good at certain things. We're not always the best at some of that stuff. And so I think that's why we need passionate clinicians. That's why we need the Health Foundation. That's why we need these Royal Colleges to be out there leading the way on what this tangibly means, because E&I can't do all of this alone. In fact, by definition, if we tried to get there alone, wouldn't happen.
Great, thank you. We'll come back to the capital point. That's a really good one. Thank you so much, Nick. So let's turn next to Sonia to give a response, particularly Nick's comments about the international agenda, but perhaps also about the NHS itself. Thank you, Sonia.
Okay, well, I guess the first point is to congratulate the NHS for being a leading light and taking this forward. And some of that's been on a journey for a while because of what's been happening in trusts all over the country. And there's a lot of people who've been highlighting the innovations and the need for this for some time. And it's true that the NHS commitment has really fueled interest around the world in how to take this forward. So the sort of alliance with the UK presidency taking on COP and trying to recruit countries to look at resilient health systems, decarbonised health systems, and also the 14 that set net zero targets is directly related to that. And I think the other contributing factor has come from COVID, the fact that people have suddenly realized that health really does matter. Yes, the climate crisis is there, it's a health crisis, but when the COVID pandemic hit us and is obviously still with us, we suddenly realized how important health is to all of us, and that it's a really good route into understanding some of these issues. So I guess one of the things I wanted to say about what we have to do going forward, I mean, clearly we need to work collaboratively internationally, because the supply chain that Nick was talking about is clearly everybody's supply chain. And what we don't want to see and has happened is when there's one system that says, we don't want this kind of product because it's not sustainable, that it actually ends up getting sold in Mexico or somewhere else where it's harder to manage. So we do have to act in a collaborative and with solidarity with each other. And that brings me then to some of the global carbon footprint of the health sector around the world, which is around 4.4%. That would be, the fifth largest country around the world. And really what that highlights is that they are very differentiated responsibilities. So we have, the US with 27% of the carbon footprint, which is actually thankfully signed to this commitment, and then Europe representing another big bunch that have a real responsibility to decarbonize as rapidly as possible. And I think it's around 7% a year if we want to be fair and just in regards to the rest of the world. So other countries who are still battling with trying to deliver universal access to healthcare have got a double challenge of trying to deliver healthcare in an accessible way and to keep it low carbon and to build resilience. And so for me, the sort of some of the things that are absolutely crucial is that we not only decarbonize rapidly within our own systems, that we support some of these countries to deliver what I call green universal health coverage, which is really a shorthand for saying, you know, a new model of care in low to middle income countries that would be equitable, resilient, and decarbonized. Because if we don't support countries to do that, and if they adopt our current Western model, we're heading for disaster in terms of carbon footprint, let alone any justice issues. Because the underlying reality globally is that if we do not do something about reducing the footprint of the health sector, it will treble by 2050. So that's, you know, we need to work even harder at reducing the carbon footprint because of that. And therefore we can all have to work together in order to do that. So there are some countries that are producing quite a lot of really interesting work, and there was a roadmap for global decarbonisation at healthcare without harm published, which sort of highlights some country fact sheets, and it's really heartening to see that, like the Netherlands, France and Germany, they're all coming up with their own bottom-up footprints, and that gives a more robust data around this. And the Netherlands have done a really interesting piece where they've looked at the impact not just of carbon, but of toxicity, waste and other aspects. And what's fascinating is that the elements that relate to medicines and medical devices are all the high impact things. They're the biggest component of all of those footprints, if we could call it that. And so within the health sector, we have got such a responsibility to address all the things that are so pertinent to healthcare. And by that, I mean medicines and medical devices. And I guess my plea to everybody here is that we don't just do it by sorting out buildings and transport and products, but that we really look to transform our models of care. Because if we continue with a very medicalized, intensivist approach, we will never get there. The maths indicate that very plainly. Our only way to get to a lower carbon, resilient and equitable health system around the world is going to be to focus in on prevention and models of care where the patient, as a carbon user in healthcare, also has some responsibility about what that looks like. Social prescribing becomes important, and actually looking at alternatives like telemedicine, different ways of doing things. And I'm hoping that we'll learn from some of our counterparts in the global south as much as we will from other partners in the global north around how to do this. But I would like to suggest that there's going to be slightly different approaches needed, and very different models of care to support that. Thank you.
Great point, Sonia. Thank you so much. Perhaps if I'll just pick up on one of them now. You know, other countries wanting to make progress, the NHS has got some advantages, doesn't it, because it's a massive procurer, I mean, monopoly procurer largely, which other countries with more fragmented systems don't have such power of purchase. If we want to get a grip on these external suppliers, I'm just wondering the extent to which your organisation has worked at all with investors who are also, you know, underpinning some of these global suppliers to put pressure through ESG on this sector. It'd be interesting to know whether you've done work in that area.
So you're right that there's, I mean, I wouldn't say that the NHS is necessarily all united and all easy at all, because it's not as unified as it might sound to other people in other countries. However, at least it does have data that's mostly all in one place, and it does have some common points of influence that are quite crucial if we can leverage them in the right way. And I also think you're right to say that we need to use every leverage point to make sure that we influence change and transformation. And certainly Healthcare Without Harm is also working with investors. I mean, at the moment, there's a discussion going on around these countries and how we bring people in to really not only try and bring the technical expertise about how we might support this transformation, but actually the financing. There's a lot of financing that's been committed through the climate change agenda that is not reaching the right places in any way. And it would be really useful if we could start describing what it needs to be, for instance, in, you know, what does green UHC look like in Malawi, so that we can really start bringing that in. I think where the US have been leading the light is that they count their investments in their private sector as part of their carbon footprint and their scope 3. So they are looking very hard at what their investment profile looks like. And I think there is, you know, obviously all big investors should be divesting from fossil fuels, and I would also say from certain toxicity aspects, like, you know, that are so crucial. It's not just about carbon. So that is a huge leverage point. And in hospitals that are private around the world that do have big investment portfolios, they could be leading the way with this. And some are already. I mean, in the States, there's some large ones that are desperately trying to do that as well.
Yes, lovely. Thank you, Sonia. Good. Let's go to, so Sonia mentions a very intriguing area about changing the forms of care. So here we have a live clinician in his fatigues. Mahmoud, you're going to, some comments from you, please.
Thanks very much. Yeah, it's great to hear the previous comments, which very much align with some of my ideas. So I am, as well as working on the academic underpinning of some of the things that we're trying to do, I am also a jobbing clinician. I think, Nick, your point about how do we change behaviour in 1.4 million people is very well taken. And I think a lot of this actually is related to behaviour change. You know, how do we change the zeitgeist to be one where every person feels enabled and wants to take this forward? And I think it's fair to say that historically, a lot of this was around estates and facilities and those sorts of things, and we really need clinical engagement. And look, it's not easy. I think one of the, so I'm just going to put some of the barriers that we might face. You know, it's cultural norms as well. So there are things around, things such as, you know, infection control, for example. I'm particularly interested in products. You know, people will wear gloves because they are told that that is the norm and that we need to do that. And let's just look at that. I mean, I've looked at my trust, for example. We, pre-pandemic, in my trust alone, we used 40 million gloves. 40 million single-use pieces of plastic. I worked out, if you put those end to end, it was stretched from myself in Brighton all the way to Mumbai. That's just one hospital. And let's be honest, they're not using that in necessarily clinically appropriate conditions. It is because it's become the cultural norm to wear gloves rather than to wash your hands. Now, of course, there will be certain examples where we need to wear gloves. Of course we do. But there's this disjoint, I think, because you know, sometimes there is infection control guidance and infection control people saying this is what we need to do when we're not considering the environmental harm of it. And in fact, hand washing is perfectly safe. I have to say my infection control team here are very much on board. They say, we don't tell people to wear gloves, we tell people to wash their hands. But I've got a colleague in Edinburgh, I was recently speaking to colleagues in Edinburgh, and they said, I was told that if I didn't wear gloves to examine a patient and I wanted to wash my hands, I would be reported to the executive board. I mean, he was flabbergasted. So we just need a bit more institutional leadership to say, no, this is actually what we need to do. And I think there's also, I mean, I've been working in supply chains for a long time. So, you know, if the SAGE committee, for example, is saying that we need to wear gloves, actually, you know, why? And there's no joined up thinking to say, actually, if you make that decision, we will procure billions of gloves from Malaysia because you've made that decision, we need to follow it. What about the environmental harm? Why did we not consider, actually, perhaps we should be telling people to wash their hands? Because, of course, coronavirus is mostly airborne. And I can tell you that through my work, you know, that has other consequences. You want gloves, you want them cheap. They're produced in Malaysia. They're all produced with forced endemic labor. That's what I've seen. Horrendous working conditions. I can tell you stories of workers who are beaten, who are locked away in factories. They're all migrants from Bangladesh and Indonesia. It's one of the worst examples of forced labor and modern slavery that we have seen in this world. And the NHS is contributing to that. And look, I take my hands off, I spoke with the Home Office, they're trying to work on that, but they are somewhat tied because the guidance is you have to wear gloves, so they have to procure them, and the power is in the wrong place. So that's one example, and we're certainly working to try and change those sorts of things. But I think there's other examples. I mean, I'm a surgeon. We know that in surgery, we use a tremendous amount of goods. The operating theatre is horrendous. generates on average a quarter of all hospital waste. And so much of what we are doing in the operating theatre is single-use equipment. We've done the analysis of that. Up to 70% of the carbon footprint of an operation is actually due to single-use equipment. Now, Sonia, you're absolutely right. The best surgery is, of course, the one that never happens, because we have people living healthier lives. We have people being cared for away from home. You know, I'm picking up the pieces. Surgery does that. But nevertheless, we are going to have operations. And again, that comes down to misconceptions that single use is better, it's more sterile. We have the best sterilization facilities in the world. Everything is standardized, it is audited. So we just need to change misunderstanding. People think that this is single use is better, single use is the way to go. But look, it's great that the industry is on board, but I would also be critical of the industry, because they have created this linear economy. I mean, they may argue you created the linear economy by saying that you wanted all this single-use equipment, but I would say, well, hang on, we need to move to a place where we are creating products that are designed to last, that are designed to be re-sterilized, that are designed that when they fail, they can be reprocessed easily. I've been speaking to some of the largest reprocessors of medical equipment, which is a huge thing in the US, and they say, well, devices failed, but they actually could be manufactured to last. Why not make them modular? Why not make them easy? I can also tell you there was a major supplier to the NHS that supplies single-use drapes and gowns, asked me to speak at a sustainability seminar. And then they asked me what I was going to talk about. I mentioned the idea of reuse rather than single use, and their executive board withdrew my invitation. So it's fantastic that we've got people on board, but let's be honest and open that we are creating a circular economy. And let's also have some investment where we say, actually, the new NHS requires sterilisation facilities easily available, repair facilities easily available, remanufacturing facilities easily available. And we don't want greenwashing, we want a true circular economy, for example, for medical products, notwithstanding all the other aspects that we have. So I think there are lots of challenges here, but we really need to reimagine how we deliver healthcare. And that also is deprescribing. Perhaps we've got some really difficult questions as well about things such as, is cosmetic surgery really something that we provide in the private sector because of the huge carbon footprint of that? Is end-of-life care really the best it could be when we are putting so many resources in, when actually we realise that some of these patients are not going to do well? Are we treating the doctor to feel like we've done something rather than treating the patient? And there's that. Doctors always want to do the best for the patient, but what's best for the patient isn't necessarily what we're doing.
Lovely, thank you so much, Mamu. Some very strong points there. I just want to point to your work that you're doing for the UK Health Alliance on climate change, which is taking a specialty approach to encourage clinician leaders such as yourself to work with their tribe within the NHS to look at these issues within the pathways of care they're responsible for. And I think you're leading the one on ENT, aren't you? So do you think that there's room for clinical leaders to do this, to come to some consensus view about reusable things, infection control and all of that, that could then help guide NHS leadership in the way that sort of management leadership can't easily do because it's not so clinical, if you see what I mean, and also to somehow influence the innovation agenda and the spend on new technologies that are then going to have to be developed to have, you know, to move away from single use and multiple use. So I guess it's the leadership of the medical profession in certain specialties is my question, and how developed that is, and what do you think needs to happen there?
So yeah, you're absolutely right. How do you turn a group of individuals who are responsible for care into a new cultural norm? I have to say, so this is, I've been asked to chair a report on surgery in general across the board, all of surgery, to make that, you know, more environmentally sustainable, and actually the Health Foundation actually funded that work, so thank you for that. I have to say, to date, it's been there's been some good people. So I have we've created an intercollegiate working group. So the Royal College of Surgeons of England, of Glasgow, and of Edinburgh have all signed up, and the presidents have said yes, we're completely on board. And I'll be frank, that is largely because of you present the evidence, you present the data, you show that there is leadership required. So I think that's really important, because it gives us, again, it's about institutional So if people are saying, you know, oh, infection control is an issue, then you need the institution to say, no, this is fine, this is the way that we do it, and it allows people to do that sort of thing. So look, we're going to, I haven't got all the answers, we're going to work through it over the next year or so. It's going to include the things like preventative care, you know, do you have lesser, lower, you know, hip replacements and knee replacements because people live healthier lives. We will talk about digitization, remote care, but we'll also talk about leadership in the operating theatre to change that. We need the industry on board with all of this as well. I'm working with some medical engineers to understand what causes device. It's a huge amount of work, but yes, I think I'm hoping that we can all come together and unite, and hopefully, you know, when people have a culture, they want to be part of the culture. The new culture is sustainable healthcare.
Right, that's great. Thank you, Mahmood. So let's finally go to Adam, who will have some broader comments from his perch at the New Scientists and looking at the wider agenda. Thank you, Adam.
Good morning. Thanks, Jennifer. I'll keep it fairly short so we've got time for questions. But I mean, I'm coming to this as a climate and energy guy mostly, you know, as a sort of health outsider. It was really interesting hearing Sonia and Mahmood's points there. Really resonated about on one side was engagement with staff being a big issue. New Scientists media parent company is talking about net zero plans, and it's very much come across that, you know, it's about people, not just buildings and boilers, which I'm sure Nick is familiar with as well. And then the other issue, which sort of Mahmood alighted on, I don't know if you quite use this phrase, but just is basically cost, right? Is about money. And you know, that's something that is played out in the wider net zero agenda that we're seeing in the sort of public discourse now that the government is moving a bit harder on some policies, and we're already seeing certain groups of MPs, for example, opposing some measures on cost grounds such as heat pumps and so on. So I just thought it was really interesting. In terms of comments, I suppose I've got sort of two brief things to say. One was about just to sort of recap about COP26, and then the second was about the UK and the NHS side of things. I guess COP26 is, you know, for anyone who sort of wasn't following every cough of it, well, I think it actually was quite made quite significant progress. I think it was a case of expectations versus hope. So obviously it disappointed the hopes of a lot of campaigners, but in terms of expectations of experts that I spoke to a couple of months before, it's actually way beyond what many of them were hoping for. The big things are the fact that all governments are going to have to come back next year with new climate plans, which is something they weren't going to have to do before. They were going to come back in 2025 with plans for the decade afterwards. That's a big deal. Whether they will or not is a big question. And then also just the language on fossil fuel subsidies and unabated coal, even though there was the sort of last minute rabbit in a hat of the story where it got watered down at the end. That's a really big deal. Neither of those have been mentioned explicitly. So I think that the subsidies point might have some read across to the health sector. The issue of health did come up at COP26, and it was raised by country delegates. I think, you know, and Nick mentioned, you know, the other healthcare systems, and that's great to see. I mean, I suppose just to say, as a sort of a bit of a reality check, it's still very much like things like agriculture and stuff. It's still just barely on the agenda and barely on the radar. You know, health is only mentioned once in the Glasgow Climate Pact, which is the sort of overarching decision text, as they call it, that came out of the meeting, and it's just in a broad reference to the right to health when governments address climate change. It's a sort of broad brush and generic as you could get. So, you know, it is climbing up the agenda there, but it is still on the periphery. I think it's worth just saying. It's not to do it down in any way, just to sort of be a bit of where we're at. And in terms of the UK, I guess the pressure is obviously now very much on, not on targets, but on policies to deliver, as you know, Nick was alluding to. And you know, I think I'm sure most people watching this will probably have read the UK's net zero strategy published in October. If you haven't, highly recommend. It's actually quite readable as a government document goes. I guess my sort of comments in the UK and the NHS side are probably more on this is the journalist in me. I might end up asking questions rather than making comments. But I guess my sort of interest is kind of, you know, the big issues for the UK this decade are going to be around transport and buildings. I guess the interesting thing for the NHS is going to be things that may be outside its control around energy supply and how people get to the NHS, how they access it and how they travel to it. And also a couple of you brought up the point about behaviour change. This is something the government doesn't want to go near because they think it's politically toxic. I talked to Patrick Vallance when I was at COP26, and he was saying, you know, we've only just begun on this. I think one of you made the point about behaviour change of staff. I suppose the question I would ask is, take it a step forward. Is there any role for the NHS using its huge sort of interface, its conversations and communications with patients to talk about behavior that both reduces emissions and improves health. I don't know if that's appropriate or not, but obviously talking about things like walking and cycling versus car, low carbon diets, do we go there? I'm sure some people are already going there, but is that appropriate, and what's the sort of role the NHS I'm interested in? And I guess, and one last thing which might seem quite geeky but is probably quite important later down the line, is I'm interested in where the sort of healthcare system stands on CO2 removals. Right, so this is obviously going to be a key part of this. This is the net bit in the name. So I'm interested in whether that's the sort of thing that might happen on, whether there's the capacity to do that, unlike the estate of healthcare systems, whether that's trees or even direct air capture machines, absorbing CO2, or if that's just a non-starter. I don't know. I'm just really interested in what the role is there for those. And I guess also just I'm interested in pre sort of net zero targets. The UK put it in law a couple of years ago. A lot of other countries have now followed suit. Pre net zero target, everyone, lots of industries thought they were in the 20%. The emissions target before was an 80% emissions cut by 2050, right? And a lot of industries thought they were in the 20%. I'm interested in what parts of the NHS still think they're in that 20%. Which parts of them, where's the inertia? Anyway, those are the things I'm interested in.
Thank you so much, Adam. Just on we'll get to the public in a minute, but I just want to ask you a techie question on measurement, because I know that we were speaking before we started this webinar about the BEIS hasn't really produced any kind of measurement or targets, have they, that they progress towards those. How accurate are the measurements that we have at the moment towards net zero in different industries? I don't know if you know specifically about the NHS, but you hear all these numbers flying around, but how accurate are they really? And is that important with moving forwards to be able to pinpoint progress, or indeed places that really do need to make more progress?
I mean, there's fairly good data on, on sectoral emissions, and that's fairly good and fairly easy to verify, because there's lots of proxies for seeing, how much energy sectors are using, such as taxation and so on, and it's all regulated and measured. But I mean, so that's not too difficult. I guess the thing for me, and also, we have very good scrutiny in the UK via the Climate Change Committee, the government's legal advisors that it's literally their job to do this, and they're very good at that, and they produce annual reports. I guess where the greater uncertainty is Nick was saying, what's important is looking forwards, and the greater uncertainty is what are the sort of best, there's still some uncertainty, right, and what the best levers are on some, and that's certainly going to be the case, particularly in the NHS, around what do we do about certain pain relief, certain anesthetics and so on. That's still and even the ambulance stuff, right? In passenger vehicles, for the wider public, it's fairly clear that the solution is going to be electric cars. For heavier duty vehicles, it's still not entirely clear, and therefore some of the sort of emission savings that we might achieve are still not entirely clear, which is comes back to what you mentioned, which is I've been asking the UK government to break down what the emission savings in the UK net zero strategy are. It gives sectoral ones, but it doesn't tell you what individual measures are, so you can't see what the big ticket items are and what the small ticket ones are.
Great, thank you very much. So thank you for all of that. We've got some great questions. Let's turn to those, because there are a lot of them. I think the first one is actually what Adam just mentioned, and it's a question about CO2 removal. And I wonder whether I can go to Nick first about that. Is that part of the NHS strategy? I should know this actually, having prepped for this meeting, but is that part of an NHS strategy? And maybe others can add in, maybe Sonia, about the international approach.
I had an angry conversation with pharmaceutical company X about a month or two ago, who said, Nick, we're not interested in net zero, we're interested in real zero, in absolute zero. And I said, I think you're lying. And they said, why? You don't even know. And I said, because I know there's no such thing as absolute zero. You can reduce a heck of a long way, but you can't get to the carbon in the person speaking to you. Yes, the NHS has a portion of, in our trajectory, a portion of our emissions that we don't reduce to zero. The trick is figure out your entire footprint, reduce as far as you can go, then reduce a little bit further, then a little bit further, then stop, take a week off, go and look long and hard in a mirror and stand on top of a mountain, and then figure out how you can reduce your emissions a little bit further. And then, and only then, can you think about the negative side of this, about the net part offsetting. So that's what we did. For the NHS's part, 6% for the emissions we control directly, 8% for our entire footprint. That's what we have currently in our offset bucket. Are we doing anything about that today? No, because we're focused on the emissions reductions. That's what we are targeting. And we're also hoping that those numbers come down over time, right? We have gone and looked at very seriously the sorts of questions I think that Adam, you were posing. What happens if the NHS estate is a big estate? What if you go and plant a bunch of trees? What if you go and take the rooftops and put a bunch of solar there? I can tell you can't power the NHS with the entire rooftop of the NHS, right? And that shouldn't be a surprise to anyone. So we can't use that as an offset. We could pretend and say we were offsetting, but unless you were able to exceed the total power consumption, it's not an offset, right? All you're doing is accelerating and contributing to the grid. If you can feed back into the grid, then sure, it's an offset. So that's not open to us. On the estate, sure, you could plant, you could take all those car parks and you could take all sorts of bits of brown estate in the NHS. Very roughly, we think it could offset about 0.8 to 1.2% of our emissions. Doesn't get far enough for this to be a serious proposition. And so, like I say, we're focusing principally on the reductions. I think we're quite proud of the 6 and 8%. I think broadly, if I had to put a finger in the air and say, where's the international standard of acceptable progress? 10%, you're doing pretty well. Intending to offset sort of more than 15%, you probably are in a conversation from a previous decade. Is that fair, Adam?
I think so. I think that is fair. I think that's fair, and certainly, I mean, again, it comes back to your point there about using the ideas about using the roof of the NHS, as it were, for covering. So again, it comes back to issues of cost, right? That probably wouldn't, but given that centralised, very large scale offshore wind is much cheaper these days, and that probably wouldn't be the best way to do it anyway, right? So you wouldn't be getting the best bang for your buck in terms of money spent for carbon saved.
Sonia, I wonder if you had any comments in the international perspective on that.
So I would definitely agree that every focus and energy and money should be on decarbonisation before really thinking through what we do with the very hard residuals. That is not the case everywhere, and I would say that to me it would be so important to focus in on how we decarbonise before we start answering that question. I mean, looking at it more globally, if you looked at nature solutions, there's no way offsets would even manage to do the offsetting for, say, agriculture, let alone all the other sectors. So we have no way around this than to decarbonise absolutely as much as we can. But there's two extra points I'd like to make. One is that there's an equity issue behind this. If we think that we can buy ourselves out of it, we're really on the wrong planet. And the other one is that the prevention piece means that you're not producing the carbon in the first place. So let's try also and focus on reducing the need for healthcare wherever we can. And I think there's a number of comments about how do we bring patients on board. I would just like to say patients are crucial to this. We're all patients in our own ways, and we have a huge influence in asking our doctors, our organizations, our trusts, our hospitals, our clinics to help us get this right. And patients don't want products that are not sustainable anymore. They want help to do this right. So I would say, let's talk about offsets when we get much closer down the decarbonisation journey. My hope, like with what Nick said, that you keep taking a week off and thinking about it again, is that as you get closer to it, we find new innovative ways of doing things differently. And that's what we've got to be focused on, is the innovation that can help us get lower and lower. We may never get to 0-0, but we need to get as close as we can. I mean, it's our duty to do that as healthcare professionals, but also as citizens of the world.
Thank you. There's lots of practical questions here. For example, a GP surgery, how do they have help to put in solar panels? For example, there's another question similarly about community health services, where a lot of the community health service workers are driving around, having multiple trips per day. How do those organisations at local level have support to do the right thing? So that's a question, I think, for Adam first off, but I'd be interested in others' views.
God, I'm gonna duck that. That feels all I want for Nick. I mean, I wouldn't pretend to be like an expert on that operationally, how the NHS should decarbonise, right, on those questions around buildings or transport. I just don't. Yeah, I think I'm going to duck that.
Yes, sorry, I said Adam. I did mean Nick. So my apologies, Adam. We're giving you a heart attack. Nick, sorry, you were let off the hook, but now you're back on it.
No, I think Adam should answer. I said it right, 20% of emissions, 90% of patient contact, primary care is essential, and that 20% is just 20% directly. It doesn't take into account that primary care often acts as that gatekeeper, determines where the patient goes from there and their emissions continue, right? We've got to get better at prevention. Everyone knows this. The long-term plan knows this. It repeats it every single day. Yeah. You can't enter Skipton House without that ringing in your ears. There are a couple of questions that I was skimming, touching on some of this, asking about, physical locations, digital care, right? It's been a big topic in the news, back and forth, and that pendulum, I'm sure, will continue to swing. What we know is that providing choice is good. What we know is that it can increase access if you do it right. You've got to do it right. If you do that right, you can reduce emissions as long as you provide choice, as long as you don't create that backlash. And it's a good example of how if you try and impose some policies, not necessarily in this case because of climate change, you will raise small armies up against you. And so I think, certainly part of a solution there that you would expect to see primary care to take on going forward. Specifically asking, solar panels, right? Very small capital grants. That is a little bit of a blind spot, to be honest, and we're having a couple of conversations with some of the people that hold some of that big capital. There are big schemes out there for decarbonizing heat, decarbonizing power in big public sector buildings. There is not that level for something a little bit smaller, like a GP practice, right? And that's something I think we do need to see. The NHS is somewhat unique in the public sector in having that many sort of very, very small buildings scattered across the entire country. But a problem nonetheless that I think we need to be working on.
Yeah,
Sonia, you had your hand up.
If you think of all those community health staff, driving around to see their patients, and indeed social care staff who are doing all the 15-minute visit.
Can I also, I saw one other question. Someone said, to what extent is personalized care, is social prescribing a part of the solution here? Oh my God, yes. I love that. Right, I had the best conversation with James, a friend of Sonia and mine, the director of social prescribing, personalised care in the NHS, talking about the ways in which it's just good medicine, it's just good public health to instead demedicalise, deprescribe, and encourage people to get out, exercise, eat healthier. As it turns out, it's also good for the climate, but principally it's just good medicine.
And I would just like to add on the sort of the care piece, that sometimes we focus maybe on the person driving around, but actually it may be that the medicines that are being produced are the biggest problem. So actually giving good personalized care in a good conversation with a patient about their lifestyles and what they're looking for, and that choice is absolutely critical. So it may be that sometimes the journey is worth every penny of it, or every bit of carbon of it, because actually what it's doing is saving a whole load of other things. So we do need to get to the point where we can look at carbon across a care pathway, so we're not just dividing it up into the traditional sort of buckets that we're used to. And there is some work that's been going on with a number of different professionals to try and say, well, so what might that look like? What, how can we compare different pathways? And certainly the personalized and agenda is absolutely critical to that, because it's about getting it right first time. And that's also another program that's been around the NHS for a while. So the focus on doing the right thing is absolutely the right thing for the climate as well. And I think it needs to be a good starting point. This should improve quality of care if we get it right.
Yes, I mean, there's good practice in preventive care and social prescribing, all those things. We all agree with that. That's a given. Some polling that we did showed that the public doesn't really, at the moment, it's not really cutting through. A, that the NHS is a huge emitter, and B, that any consideration of net zero should be part of a clinical consultation to do with care. So there's a massive public narrative to be developed here, isn't there? Mahmoud, I don't know, given your proximity to patients, whether this is ever coming into the clinical conversation and whether you think actually it's appropriate to do that, or really whether clinical considerations themselves come first and only those should be considered. Yeah, Mahmoud?
Yeah, no, it's an interesting question. Look, we've done a little bit of work and I think more needs to be done. Oh, can you hear me?
Yeah.
Can you hear me?
We can.
Yeah, oh, sorry. We've done a little bit of work with some patients, and it mirrors what you may have found, that many of them sort of don't want this to be part of the clinical conversation. And I suppose it comes about responsibilities. I think a lot of patients actually want to come in saying that they want to actually, you know, that what they care about as a doctor is doing what's best for them. And that's what doctors want to do as well. I think that more work needs to be done around that, and perhaps there is some more education, but also I think perhaps there's a difference in that what you have control over is your lifestyle, of course, how you got to the hospital. And that's perhaps a more useful conversation to have. Well, are you eating, you know, what sort of food are you eating? Oh, actually, you know, perhaps there's healthier lifestyles, there's exercise. Oh, I could prescribe you a blood pressure tablet, but actually, you know, why don't you do some exercise and maybe we won't need to pump you full of medicines for the rest of your life. So I think that's something where, and obviously we don't want to be preaching. So, I mean, I'll admit, quite a few of the patients I see that are waiting for operation are overweight. And I explain to them, you know, in a non-confrontational way, I would say, well, how has your weight been? And often a lot of them will recognize the problem themselves, and then I give them some useful advice about, you know, portion size, the types of food they're eating, and doing some regular exercise. And always say, do something you enjoy. I have to say, I'd say around 2/3 of them have done it and said, actually, I do feel much better myself. So there's that aspect of healthier lifestyles. I think when it comes to actually providing care, we are the experts. They look to us to just say, okay, you do what we think is right. But there's no reason that sustainable healthcare isn't the correct healthcare. So, you know, these ideas around infection control, I'm never saying that we should put patients at risk of infection. I'm not saying that we shouldn't use the appropriate equipment, but sometimes we are just doing the wrong sorts of things, I think. So I think there is that disconnect. I think the patients, from my experience, just want the doctor to do what's right. But if that includes sustainable systems, then I don't think they would necessarily object to it, as long as you can be clear that we're not compromising their care.
Yeah, and do you think all of this should be part of the face-to-face discussion versus virtual that seems to have, you know, Daily Mail's had got a big campaign, hasn't it? And do you think the conversation with the public net zero considerations should be included in that? Because it isn't at the moment, is it?
No, it isn't, and perhaps we do need to bring that in. But I think I take Nick's point. What we don't want is a backlash. You know, to create behaviour change in, you know, the entire public, in 1.4 million workers, we have to be careful as to where we could create backlash. So if we want, oh, that, you know, that remote consultation is just they're just trying to meet some agenda rather than care for the patient, then we could get a backlash. But of course, we do need that. And even doctors are a bit tired, of course, of remote consultation. And I'd say, well, it's not that we just say it's out. We say, where can we do it? And where is it appropriate? I've done some work on patients with recurrent tonsillitis. Actually, I don't need to examine them. The history is what's critical. We did a study where we just rang up these patients, new patients. They were all working age or they were studying, and they were all delighted. They didn't have to come to the hospital and disrupt their day. Some of them had childcare. So it's great. And for us, it was fine as well. So I think it's a case of finding out where it can work.
Very good, very good, thank you. But there's a whole load of questions and suggestions about how the carbon footprint might be reduced by certain actions in various places across the NHS, from bamboo shoots to better recycling of clinical waste and so on. So I guess one of my questions then is how best can, if there's all sorts of innovation on the ground and people very excitedly, you know, putting together ideas, how best do we learn then across the NHS faster than we have before, and before consensus can filter up to national level and create guidance? So how best can we do this organically? Who'd like to have a go at that? And maybe after that I turn to Adam to see if there's any other industries that do this well that he might be able to point to. Is that Nick again? And maybe Mahmoud.
I'm very happy. We've got to do better at this, right? let's be very honest. The world has talked about, cared about, desperately worked towards tackling its emissions, climate change for 3 decades. Healthcare's been a little slow, right? We have only really hit the prime time just very, very recently. People have been working in it for quite a long time, but it really hasn't hit the main event until just now. And so we have a lot to catch up on. We have the beginnings of good ideas, but I don't think we have quite enough tangible, practical things that people can go and do day after day after day that we can start to share. So number one, I think we've got to grow the number of ideas out there. The sorts of things that we're trying to do, we have invested in each of the 7 regions to provide small grants, 5K, £10,000, out to individual wards, out to individual clinicians who just have a good idea. They think it'll reduce emissions. They think it's something that could be scalable. And we'd like to try that out because we're going to have to invest in some of that new thinking. At a slightly bigger scale, innovation grants, I mentioned one of them forthcoming for primary care, but that wasn't the first one. We've actually run a few competitions earlier on this year. £100,000, looking at slightly bigger programs where we could start to say, actually, we've tried this a few times. It worked really well. Could it get to the point where this could be adopted wholesale by the NHS? Those are those sort of IRLS, SBRI grants for people that love acronyms. And then even bigger again, right? NIHR announced only half a second ago. Go and look it up if you haven't seen it. £20 million investing in new research for low carbon healthcare. First, you get those new ideas, then I think we have to start socializing them. One of the biggest mechanisms we hope we have to start that socialization process are our clinical fellows, new clinical fellows, first 10, soon to be 30, scattered across the system, some of the best doctors, nurses, pharmacists, physios out there leading low carbon healthcare projects. And secondly, we hope this process, once we get these green plans in, these net zero strategies, the assurance process is not going to be punitive in the first year. It is going to be about peer review. It is going to be about shared learning. It's going to be about taking best practice and seeing how we can all work together to slowly raise that bar. And so we hope to run quite a large consultation and engagement process between each of the trusts, the ICSs and the regions to try to get better at exactly the question you just asked.
Yeah, just sorry, I'll turn to my mood in a minute. But if you think about the, the pandemic, all the docs linking with one another through WhatsApp and everything with rapid consensus development, is there some equivalent sort of mass sort of connection system that we haven't yet developed to collect all these wonderful ideas on the ground and share good practice before the evidence rolls in from longer NIHR studies, for example?
If there is, the Health Foundation will be the people to find it first and trial it first and help us adopt it, right? Look, there are some platforms out there. Future NHS is one that, is out there, everyone's familiar with. Is it amazing? No, it's okay. Does it do the sort of, innovative interdigitation and new synapses forming all the time that we're after? No, not really.
We have funded, I'm sorry, this is maybe this is a conflict of interest, but we have funded something called Discovery, which is based out of this institute in Cambridge, which is a rapid system of consensus development that's being used at the moment to improve maternity safety and child safety in newborns, reduce birth injury. So that's being trialed, but that is such a system. It won't be the only one. So I'm just thinking that could be while you wait for the evidence to roll in. Mahmood, I don't know if you have any suggestions. Are you on any of these rapid synapse WhatsApp groups that could be helpful?
No, I'm a bit old-fashioned. I talk to people a lot. So this is, we do have WhatsApp groups, of course, within the hospital for people who are interested in this kind of local cultural change. I think a lot of it is to do with knowledge, attitudes, behavior, which creates that cultural change where we move towards. And so things like these sorts of webinars are good because actually it can hopefully spread some of the knowledge and we're creating the evidence to actually say what we should do. So for example, if I can speak frankly, recycling is obviously always a hot topic that people really want to do, but we know that recycling is not the key. It's only going to recover a very small part of the carbon footprint, and reduce and reuse, reduce, reuse, reuse is the mantra that we need to get to people. And people just need to have that knowledge to understand why. Attitudes, I think we're on a positive I try to stay optimistic about these. I think we're in a positive area because actually people do care about climate change now. Having worried about it for 15 years, there's this stuff in the air that could kill us. Suddenly people realize there is something in the air that can kill you with COVID. It's just might kill us a bit slower, but now it's urgent. And I think the attitudes have changed now. And I think amongst doctors as well. If you talk to NHS staff, most of them are really, really passionate about this. They just need to be given the tools and the authority to create that change. And so the behaviors we can demonstrate through examples of what people are doing. This is what your people are doing. You can do that as well. And then we create that cultural change. And actually, it's a win-win. For example, we've done some stuff with accident emergency. In our trust, there was single-use instruments used in accident emergency. You suture someone up and you throw it away. 3,000 of those used every single year. And I said, no, actually, you should be using reusable equipment. And they got the equipment, they linked up with sterile services, it's all labeled, it's all brought back. They got these instruments and they were amazed at the quality of the instruments because, of course, they're designed to last, they're designed to be reused. It's about making those changes easy as well. What we don't want is barriers to change. That's people want to do what's a convenient thing. As Al Gore said many years ago, an inconvenient truth. We all like to live our lives, so we have to create behavior change. We have to make it actually that equipment that we're getting in the accident emergency is fantastic equipment. You really, really do want that. That's going to make your life easier and will make the sterilisation of it easier. I trust we're trying to reduce it to zero, but there's still a few surgeons who are using it. As the clinical lead for a trust, and maybe people will hate me for it, I've said, well, actually, you now have to fill in a form to say why you're using desflurane, just so we can monitor it. Yeah. And that can be just that little barrier that makes you think, oh, I can't be bothered unless I really, really do need this for my patient, in which case you will bother. So, yeah.
Very good. And Adam, I just wanted to point to you, are there any other sectors where you think there is sort of rapid learning across in an initiative way, sharing practical experience that people...
Sure. I mean, I guess the obvious one to point to is the power sector, which has been very good at decarbonising in the last decade and is also very good at throwing things at the wall and see if they stick. Very good at working with, companies, working with academia, everything from batteries to smart grids, electric cars sending back to the grid, dynamic demand where, you turn down the amount of electricity that people are using at times. So there's lots of interesting stuff going on there. Worth saying a lot of that's supported by, UK government money ultimately. I suppose I'm not entirely sure how much read across there will be to the health sector there, because a lot of that is sort of profit driven by startups looking to, get bought by a bigger company or develop scale up technology. I mean, some of it is definitely funded by bodies like, UKRI, and there are government pots of money, so some of it might have a read across. But I think, that is a sector that has been very good at just doing quick trials and either dropping them or scaling them up, and is quite good at sharing as well. It's across the industry.
Yeah, this becomes relevant, I think, if you think of the 80,000 sort of global suppliers to the NHS and how they are rapidly going to learn. There'll be some big suppliers, but there'll be tons of little ones, won't there? So, Sonia, I don't know whether there's something on your radar.
Well, I think that what we're touching on here is something that's quite critical. As this change is accelerating, our sort of models of learning and of leadership need to change and to be able to be much more responsive to emergent thinking and different things that are happening. Yeah. And we also need to be able to question our sort of assumed wisdom, maybe that some things that work now might not work later and so on. So for me, there is a real need to consider the skills, leadership, sort of learning patterns that we need to be putting in place for the future, because otherwise we'll be too slow to respond to the acceleration. And as a sort of slightly older person myself, I'm really quite, keen that we think that through. How can we support emergent leaders to do that well? And some of it is about letting go and not needing to be in control. And like Mahmoud said, trying things and having a very quick turnaround. Does this work? Doesn't it work? Ditch it if it doesn't. If it does, keep trying. I'm sure that there'll be lots of academics who'll be looking at the best ways of doing that, and we need to accelerate that ability as well.
I think that's a really good point, and actually that touches on one or two of the questions about leadership, about so much of leadership in the NHS, for example, doesn't necessarily have net zero as part of a strand of its work. but also, as you say, how can we not wait for evidence and just work fast, iteratively, crowdsource consensus where evidence hasn't yet emerged, and just move forwards now, taking Nick's tempo, so that but to do that, people need cover, don't they? They need to be given permission, but they also need to be able to iterate with a wider group of people so they don't feel out on a limb. So I think that's a really important. So again, these virtual sort of crowdsource mechanisms to develop that kind of consensus and give people confidence is possibly a really good way forwards, whether you're sitting in the NHS or whether you're sitting in the middle of 80,000 suppliers who otherwise would just be doing their own thing. That's great. So we're coming near to the end of our webinar now. We could go on forever, couldn't we, on this? But I think there's probably two things I probably want to just go round you all with. One is that a lot of people are obviously asking questions. They're individuals sitting inside the NHS somewhere. What practically what is the one thing that they practically could be doing to either themselves direct action or contacting others to start the ball rolling where they are if they don't know what's going on? I suppose that's the thing. And then I suppose the second thing is, from your perspective, you know, what's the one major take-home message from today's webinar that you think that would take us forwards faster in the next 6 months? Sorry, that's a hard one, isn't it? But so maybe firstly on the what do I do? I'm a nurse in a hospital. I'm new to this. What do I do first? So Mahmoud, maybe you first, I think.
Sure. Look, there's lots of things, of course, you could do, but I would say it depends upon what sort of support you've got. This is about creating a culture of different change. You need to create a coalition. When I started at my trust, I went straight to the chief executive. I've asked for a meeting with the chief executive. This was actually 3 years ago, and then this pandemic got in the way, to say, are we going to do this? Is this one of our values? And at University Hospital Sussex, it is part of our core strategy. Sustainability is one of the pillars of our organisation. So I got that high-level leadership, because once you've got high-level leadership, it then enables culture change. This is how we do things as part of institutional support. So I think you need that, and then you need to create coalitions of people who think like you. So you create a body, a mass of people. So it's not one thing, there's so many things, but that culture.
Right. So connect with others, I think, is the main. That's great, thank you. I'm mindful we've probably got 2 minutes left, so maybe it's just really 10 seconds from everybody. That's cruel, isn't it? So maybe Nick next on either of those questions, what to do in the next 6 months, or what do I do if I'm the nurse in a hospital?
The strength in numbers. Number one, go and find a friend. I promise you 9 out of 10 of your colleagues want to see action on climate change. Most of the people around you want to do something. Number two, go and do what Mahmoud did. Go and ask, do we have a green plan? Do we have a net zero strategy? How can I help? Number three, think about a piece of carbon that you uniquely control, no one else but you, and go and change it tomorrow morning.
Wonderful, thank you. Sonia?
So in addition to all those things, I would just think about what are the skills and leadership style that you need for the future, and start preparing for doing it today.
Lovely, thank you. Adam?
Just really echoing what the others have said. I mean, just remember that public polling shows people are with you. You know, this subject is third only to health and the economy. And you know, just to relay an anecdote of, I was interviewing Greta Thunberg this year, and one of my daughters asked her at the end, she snuck in and asked her, what's the one thing you would do if you had a sort of superpowers, what would you do on climate change? And she said she would change people's minds. And so just really echoing what other people are saying, which is talk to people. It may sound like it's just more talking shop, but as you know, and someone in the chat mentioned living in a bubble, but that is the reality of how things change. You know, it's all about culture change.
That's lovely. Thank you all so much. So we better end it there. Thank you so much. We could have gone on, but I thought we got some really meaty issues out on the, if that's not a PC term these days, out on the table. So thank you all very, very much. So big thanks to Nick, Mahmoud, Sonia and Adam for today's wonderful insights. A reminder that the recording today will be on our website, as I said before, on 24 hours on demand. We have a lot of other material on our website, as you can see here, on sustainability. Please do check it out. The link is there, as you see. And if you like this webinar, you can sign up for updates on future webinars on equally interesting topics. but maybe not so pressing, using also the link there that as shown on screen. So I think that's all for now. So to sign off, thank you very much, and very, very good luck on your green journey. As Nick said, and well, as everyone said, act now, do something in your own with your own agency that's in front of you that you control, and look forward to further discussions and progress on this very issue. Thank you very much. Take care. Bye-bye.